Hello everyone, my name is Dong-un Lee, Associate Professor, Wongang University College of Dentistry. Today it's very honor and pleasure to be here in front of you with friendly, wonderful, distinguished speakers. Today, my topic is about the management of peri-implantitis. Including me, it is very quite headache for clinician. So anyway, over 30 minutes, I hope that is meaningful and meaningful time for all of you. This video clip was taken by Dentium CEO, Dr. Jung Sung-min. It is very wonderful time and wonderful place to tour to Korea. So I hope that you all have a good time at beautiful place. Let me show this slide. As you know well, after 6 weeks non-surgical therapy, it is difficult to control the pocket depth and inflammation. We have to select the surgery. The surgery broadly divided into the resective surgery and reconstructive surgery. This photo, representative photo showing how many type of burr to refine and polishing the surface, the tungsten burr and the diamond burr and the greenstone Arkansas burr to refine the surface. And after that, we can move the marginal, the gingival margin to the top, from top to apical. This photo is representative photo showing the bone graft after surface decontamination, such as TN brush, and then we have to check the potential regenerative. We call reparative potential. And then we can feel the bone according to bone defect configuration, such as osteogenocollagen. This is my topic summary. First, shift to aerobic environment. Second, defect-specific approach. Third, positive bone architecture. Fourth, implantoplasty and surface decontamination. The final, the soft tissue and prosthetic synergy. This slide is made by the Google Translator. I can't read it, but I hope that my topic you can understand by this slide. How about that? Okay. And this is the first patient in my lecture. He referred from my colleague, prosthodontic professor. Main chief complaint is the bone loss in radiograph. As you can see, the first implant, first implant, clearly bone loss around the implant. But we have to know before diagnosis peri-implantitis, we have to check the previous radiograph. I can get 1 year ago radiograph. As you can see, we can determine the progressive bone loss. Comparing this patient also clearly bone loss around the implant. But I can get the 3 years radiograph. Also, we can compare with the 2 radiograph, such as this. How about that? This marginal bone is quite stable. composite previous patient. So these patients can be checked by me or clinician regular checkup, such as this. So this paper about the diagnosis, the peri-implantitis, in conclusion, while hints can be obtained through visual inspection and proving, comparison with previous radiograph is necessary for the final diagnosis. We need not cross-section, longitudinal data. So at specific time, at specific period, the bone loss cannot be determined for peri-implantitis. We need longitudinal data. This article shows the graph, the number of implant removal in Korea necessary. Blue bar is implantation. Sky color bar is removal. It is gradually increasing and exceeding 20%. And also this article shows the removal case have doubled over the past 5 years. It's very increasing removal case. So I believe that we have to move from implantation to management, I think. This interesting article, it is about the cross-sectional study, about the patient perception. Absolutely, the implant removal is main reason is peri-implantitis, about 64%. In conclusion, patients who have experienced failure tend to avoid receiving retreatment for same clinic, same doctor. So we have to manage the peri-implantitis. Also, we already know about the peri-implantitis, such as this, difficult complication, microbial inflammation, irreversible bone loss, prevalence. Also, many my friend doctor, why do you manage implant, peri-implantitis? Just remove, just re-implantation. But as you don't know well, most clinicians select the removal and the re-implantation, but all patients cannot receive the re-implantation. Also, this article about the re-implantation success rate, they conclude that post-implant success rate is 94%, but re-implantation reduced the success rate 77%. So we have to control. Re-implantation cannot guarantee success by this article. So peri-implantitis, many study and evaluate, and there we can easily access the article. So I summarize, this is new classification about the peri-implantitis. Class 1 is the vertical. Class 2 is horizontal. As you know well, the already implanted top area above the bone housing. And then type 3 is combined. So we have to select the type of surgery according to the bone defect configuration. So Dr. Monje said too, class 1B is most prevalence. So we have to select the surgery, this type of defect. So the 2006, the Frank Schwartz, his article about the most prevalence is circumference. But now it's changed, the most prevalence changed. Why? I think that implant design and connection is changed. So it is the cause of the change of defect, I think. So this illustration is helpful for us to understand the defect area. Class 2 is horizontal. So most of paper recommend class 2 is rejected. So this article is about the combined therapy. I summarize that. I can summarize. We have checked the potential regeneration. So top of at the SN tooth, top of bone in the SN tooth is line. We image the line, and above line of above implant area is difficult to maintain the bone. So we have to polish. But the above, the underneath line, intraosseous defect, we can try the bone graft after decontamination. So also we have to check the inside bone, outside bone. So this type defect is outside. This defect also outside. But this type and this type at inside. So we have after decontamination, we have checked the defect type, and we have to select the bone graft or polishing. So reparative potential is very important term. This paper describes that this line is the potential of regeneration. So above area, difficult to maintain the bone. So we have to polish. But underneath the line, it is potential of regeneration is high. So we have to, we can make the decontamination and bone graft by osteogenocollagen. So this line. And then we use the tungsten bar and Arkansas bar can be used. This patient is the representative case. As you can see, the first premolar area is deep pocket, so we have to, it is difficult to control. So, as you can see, so the cause of many factors, so the manager of depth control and patient's compliance and so on. So, first visit, I try to manage you application ointment, and then she came again the 1 month. The inflammation could be subside, but long depth, long pocket depth is the maintained. So I recommend the surgery. She accept my suggestion. So this video clip is the short summary. As you can see, remove the processes. It is very important. After removing processes, we can easily access the bone defect configuration and also apply the many kind of the device such as the Alcazar ball and the tungsten ball. So also I make the vertical incision because I make the marginal level from the top to the apical for reduce the pocket depth. And then full thickness prep is needed because the full thickness prep is the easy to find the bone defect, type of bone defect. As you can see, this type is class 2, horizontal defect. So we cannot make the bone graft. And also, many type of ball can be used. Finer Arkansas bar for refining implant surface. And then titanium particles such as dust can be easily removed by the ultrascalar, and the palatal area is a sealing procedure for the reduce the pocket, such as this area, such as this motion, and then suturing. This radiograph is comparison is before polishing, after polishing, so-called the implantoplasty. And then 2-year follow-up. She is good compliance, so every 3 years she came here. She came to me, and then airbrushes and TBI also, such as this. And 3 years, the radiograph is a little stable marginal bone level. Maybe at that time, in near future, this implant removal. And then I recommend adjust the superstructure, for example, the major cantilever type. And then I like to say about the positive architects. When we do the distal wedge procedure, such as this, we incision the line and remove the distal granulous tissue, such as this. And then we have to check the bone architecture. The lingual area is the minor torus, so this is difficult to cleaning the food or plaque. So I have to broadly polishing the bone, and then you can see the smooth area. And then I make the positive architecture from the negative to the positive. So I think same approach is required to peri-implantitis too. She suffered from every brushing difficult to the access and food infection. Also, second carries the involved about the food infection too. So I recommend the surgery. She accept. The full thickness prep can be easily bone defect unfavorable. So also the implant already outside of bone housing, such as this. So also the lingual area is big torus. As you can see, the buccal side and lingual side not positive architecture. So we have broadly removed this area. She can easily make the cleaning. So also the big torus cannot make the access. So I make the polishing this area. So secondary intention healing, and then she easily make the brushing, interdental brushing, pure part of the second healing, as you can see. But finally, the good healing. And then, although the narrow KT band, but the presence of vestibule and the presence of embrasure, she was happy to use dental brush. Also, this is the classic article about the positive architecture. Also, importance the embrasure, important contact point is very. It is also same principle to implant, I think. Also, this article about the surgical treatment following the gingival recession following the surgical approach. So rejective surgical procedure also the significant recession. So also we have to need the SPT, supported therapy, for the cleaning around the implant, this area. So I need, I sometimes airbrush device this area. Also, SPT compliance have high rate tooth loss. So patients with low SPT compliance have high rate tooth loss. So SPT is very important, especially after surgery. And then this is about the pre-gingival graft. This is 20 years cohort study, so it's very meaningful for us. The group 2, first group is 2 millimeter over KT band group. Group 2, pre-gingival graft group. Group 3, no KT band group. The 20 years cohort study result, peri-implantitis is 5 times more. So if it is possible, we make the pre-gingival around implant. So KT band is important, the long-term result. So this patient is very suffer about discomfort. So remove the superstructure and the subside of the gingiva, and I make the partial thickness flap and the pre-gingival graft. After that, when I use the pre-gingival graft, I use the 3 customized surgical stand. So this is the already prospective study to compare the conventional type of Omnibag. Also, I published recently, so undergoing the patent application. So I look forward the many clinicians in near future to use it. Anyway, for most of patients cannot apply the autogingival graft because she is the systemic disease or refuse the surgery. So at that time, we need a substitute. So this patient is narrow patty band and low vestibule. So I recommend the surgery for pre-gingival graft, but she is very scared about harvesting gingiva. So I'd like to the application collagen graft X2D. So this like this. And then the healing pattern is good, and 2 months and the 3 months. So as you can see, the deepening vestibule and maintaining the KT band, so it is very good device for the pre-gingival graft. And also, decontamination for peri-implantitis is most surgical approach is the rejective. For me, the 10 patients, for example, the 2 patients is regeneration, 8 patients is rejective. So most patients receive the rejective because the reason why implant position is not unfavorable for the regeneration. But if we have chance to regeneration for the peri-implantitis, decontamination is very important. So this study already done about the alteration of the implant surface. They conclude titanium brush type, such as the TM brush by the Dentium, and airbrush is less change of surface. So it is good to devise. It's good to devise for before bone graft of peri-implantitis, I think. Scalar and PEK device is not good for regeneration. So also the 2024 AOAAP consensus re-osseointegration quite good positive result. I think the Curate Ultra instrument, titanium, nitride brush, airbrush, it is no best way to clean the implant surface. When I do the surgery for peri-implantitis, all device I can do the device for the decontamination. Anyway, it is such as the immediate implantation. Peri-implantitis defect always penetration, transmucosal part, as you know well. So poncho-like technique is needed. So at that time, the collagen graft X1D is very helpful, such as this technique. So it is the example case, immediate, and then superline implantation have a good initial stability, and I use the collagen graft X1D. The open area is very good, the healing pattern initially, and then poncho-like technique and suturing. You can see the good healing initially as this, especially this area is very good initial healing. So I use the collagen graft X1D is open. I expect the open area such as this. So I usually use the X1D this manner. So I think the peri-implantitis, when I want to the reconstruction about the peri-implantitis, so I use the collagen graft X1D. This is another case. This is the conventional collagen membrane. We always see this healing pattern. It is not eventful healing. Just wait. We can secondary intention healing, but the initially healing pattern is different. So I think the advantage of collagen X1D. So usually, recently, when I use the peri-implantitis management for the reconstruction, so I use this manner. So remove the processes and incision, and remove the granulation tissue. And previously clinic, the incomplete implant plasticity. So we need the Dr. Bonje, for one implant, take the 10 minutes for the polishing, for refining. So it is incompletely. So anyway, he want to maintain the implant. So I the decontamination and check the reparative potential. So we can guess the line, and I try to make the reconstructive. So we have to check adjacent tooth of the bone level. So TM brush is required for the between the thread, and then collagen graft 1D poncho-like technique, because always we encounter the transmucosal part. So the osteogenocollagen is helpful for the stability, and then apply. After collagen graft 1D is the cover and suture. So sometimes I use the oral pack, the initial stability, and then 2 days healing. So this is my lectures, the summary, and then this is also the translator by Google Translator for you. So, okay, I can wait. Yeah. And then not end. Yeah. So finally, the non-surgical treatment have limitation. So surgical intervention is often necessary. The access is easier if the process can be removed. Rejection versus reconstructive surgery with or without implantoplasty. So final, various methods for cleaning the surface. So SPT is very important. So how to manage peri-implantitis, reject or reconstruct. Reject or reconstruction is by according the defect configuration. Reparative potential is very important term. If reconstructive, what kind of material? Not yet the best, but the combination xenograft and cross-linked membrane will reduce the pocket depth. So collagen graft 2 and osteogenocollagen is some helpful for case. Thank you for listening. Thank you.